wait just a minute. People are just joining in, and then we will start in about a minute. Thank you. So while we're waiting for just a few more people to join, you can just state in the chat box where you're joining from, what country you're joining from. Would love to know how far and wide our publicity went and to know where everybody is joining us from today. Okay, so I believe we can get right into it already. I want to thank everyone for joining the meeting today. And I also want to thank our guest who has promptly been on the call waiting for us all. I'll briefly introduce her and then she can get right into our presentation for today. Um, Before I say anything about her, I understand that due to the time difference, she's making a lot of sacrifice doing this presentation to us. And perhaps there are other participants who are also in the same time zone and it's close to their bedtime. So we really appreciate this sacrifice that you're making for us. Right here in Nigeria, it's just about 3 p.m. So it's still very much within the day for us here. So our speaker today is Dr. Elaine Khan, and she is the Chief of Radiology at Hong Kong Children's Hospital. She's an honorary clinical associate professor at the University of Hong Kong. She trained in radiology in the same country and specialized in pediatric neuroradiology and fetal neuroimaging in the United Kingdom. She was instrumental in establishing Hong Kong Children's Hospital in 2018. She's a board member of the Asian Oceanic Society of Pediatric Radiology, and she serves in various roles at the Hong Kong College of Radiologists. Her expertise includes neuroimaging, fetal neuroradiology, interventional radiology, and quality and safety. Topic we're considering for today is fetal neuroimaging as advertised, and it explores the critical role of protocol optimization in fetal brain imaging. It highlights key MRI sequences that are used to assess conditions such as fetal brain malformations, injury, and neurodevelopmental abnormalities. By examining how carefully selected imaging protocols can improve lesion detection, enhance diagnostic accuracy, and contribute to better outcomes for both the fetus and the mother, we emphasize the transformative potential of advanced neuroimaging in prenatal care. Um, Please welcome with me our speaker for today, whose profile shows us that she has every right to be able to talk to us extensively about this. Dr. Elaine Khan, you're welcome and you have the floor. Thank you.
Thank you so much, Dr. Fetal. And that was a very kind introduction, and it's my honor to be with you all. Even though we're in a different time zone, it's 10 p.m. over here. I'm wide awake after a few coffees, and I'm glad I'm able to join you during your afternoon. And I hope you enjoy the next hour when I share with you my experiences on in fetal MRI, and like to hear from all of you as well. I have nothing to declare, but I would like to thank the Neuroradiological Society of Nigeria and Dr. Godwin Obali for your kind invitation. I'm really thrilled to be with you all here this afternoon from Hong Kong all the way to Africa. I would also like to thank Professor Mary Rutherford, who's a pediatrician specializing in neonatal neurology. She's at the King's College London, and she introduced me to this fascinating world of fetal neuro MRI. Professor Rutherford has worked with MRI for over 30 years. I'm also grateful to my MRI team, my maternal fetal medicine collaborates, and Professor Winnie Ju for sharing her cases with me. So this is us, Hong Kong Children's Hospital. We were born in 2018, so we're very young. We're only 6 years old. We're located right in the middle of Hong Kong. If you've been to Hong Kong before 1998, that's a couple decades ago. This where we're located is right where the old international airport was. So right in front of us, so we're located at the terminal of the airport, the old terminal. In front of us is a nice long runway, as you can see on this Google map. And then in front of the runway is the famous Hong Kong Victoria Harbour. So we have a very beautiful view of the Hong Kong Harbour. So I did some calculation to get to where you are to where I am. So if you're in Abuja to fly to Hong Kong takes over 20 hours. If you're in Lagos coming to Hong Kong, it takes about 17 hours. So we are quite a distance away, but I'm so glad now we have Zoom and all these webinar tools that's brought all the continents so much closer together. This is my team, well, part of my team who were there for the photo that afternoon. We have 7 full-time pediatric radiologists on our team, just over 20 radiographers or technologists, depending on where you're from, and a team of close to 20 clerical staff, as well as patient care assistants, and a team of 5 nurses. And we are also part of the much bigger Asian Oceanic Society of Pediatric Radiology family, as Dr. Faraday introduced us. So we have these annual AOSPR meetings, and the one in 2023 was held in Hong Kong. So the faculty, you can see in the top right corner photo, came to visit our hospital back in 2023. And we're a very close bunch of radiologists. And at the bottom right corner is a picture we took at the European Society of Pediatric Radiologists meeting last year. So we do see each other several times a year in different pediatric radiology meetings. And we hope to see you there as well. Even though we're only 6 years old, we try our very best to develop subspecialties in the realm of pediatric radiology. So currently, the subspecialties we offer at Hong Kong Children's Hospital include fetal and postmortem imaging. Neuroimaging, we have 2 main teams. We have the neuro-oncology team and neurometabolic team. We have cardiac imaging, musculoskeletal imaging, interventional radiology, and oncological imaging is very much our bread and butter. We are a tertiary referral center. In radiology, quite a bit of our work is oncology. So each team is headed by 1 subspecialty radiologist. So this is us on the video. On the left side is illustrates delivery of our second magnet, which was a 3 Tesla. That was about 3 years ago. Our first magnet was a 1.5 Tesla. So we have 2 magnets. So in addition to these 2 MRs, we are proud to have an MR compatible incubator. We have an MR simulator, and MR compatible audio visual equipment within the department. All these enhance our capacities and capabilities to ensure that we provide a children-friendly environment. So, the first description of MRI during pregnancy was actually published by Smith and his colleagues in The Lancet back in 1983. But I think the pioneer of fetal imaging is actually Leonardo da Vinci. His drawings of embryological studies were conducted between the years 1510 and 1512. After his surgical exposure of a fetus within a cadaver, Leonardo's subsequent drawings portrayed an accurate understanding of the umbilical cord as consisting of vessels. When the potential of MRI was first discovered in the 1980s, it was limited by the long acquisition time, fetal motion, and maternal respiratory artifacts. Since then, there have been much developments. So in the next 40 minutes or so, we will take a look at these four topics. First of all, why we do fetal MRI. I will compare ultrasound and MRI and the indications for fetal MRI. When we do MRI, so look at safety and timing, how we do it. We'll cover techniques, normal development of the fetal brain, and cover some abnormalities. And lastly, I'll briefly discuss what we can offer beyond the fetal brain. Now, so let's start by asking ourselves, why do we MR the fetal brain? Is it because overall diagnostic of MR is higher than ultrasound? Is it because fetal MR provides additional diagnostic information in almost 50% of the cases? Is it because MR changes prognostic information on 20% of the cases? Or is it all of the above? So if you're familiar with examination style, then this kind of question, usually the answer is all of the above. Now, MR is more sensitive because it has a higher spatial resolution. This is a 35 gestational weeks fetus. The brain is normal. So you can compare the ultrasound right here with these three MR images. So there's higher spatial resolution, higher contrast resolution, and we also have a multiplanar acquisition. This UK multi-center landmark study led by Professor Paul Griffiths from Sheffield University prospectively looked at 570 fetuses that had fetal MRI within 2 weeks of ultrasound. And they found that fetal MR influences patient counseling. Why? It is because ultrasound was accurate in about 70% of the fetuses of gestational age below 24 weeks and 64% in 24 weeks and older gestation. And by adding fetal MR to the diagnostic pathway, it increases the diagnostic accuracy to 92% for fetuses younger than 24% and 94% thereafter. Prognostic information was changed in at least 20%, leading to a change in clinical management in over 1 in 3 cases. Now, following up on the Meridian cohort, Professor Griffith's team studied whether postnatal neuroimaging after age of 6 months changed the diagnostic accuracy of fetal MRI and its ability to predict developmental outcome. So what they found was that the diagnostic accuracy of fetal MR remains higher than ultrasound, and it is better than ultrasound for identifying children with normal outcome. Now, so what are the indications for fetal MRI? According to the Society for Pediatric Radiology, they stated that the indication for fetal MRI are an abnormality on ultrasound that is not clearly defined, and more information is sought in order to make a decision about therapy, delivery, or to advise a family about prognosis. So these are potential anomalies in maternal obesity, in oligohydramnios, or advanced gestational age. Number 2 is an abnormality that is identified on ultrasound, and the treating physician desires MR-specific information in order to make decisions about care. And the third indication is a fetus is significantly at risk for abnormality that will affect prognosis, even if no finding is discovered with ultrasound. So an example would be neurologic ischemia after laser ablation of placenta and placental anastomosis in twin-twin transfusion syndrome. And as for indications of MR of the fetal central nervous system, a bit more specific now, there are some recommendations from the European Society of Pediatric Radiology Fetal Task Force. Now, what they said was that the indications there are four. So first of all, familiar history of severe brain abnormality in a previous pregnancy in the absence of possible early genetic testing to look for subtle similar signs if this remains questionable or if this is considered easily overlooked from detailed ultrasound. These include examples are posterior fossa malformations, gyration anomalies, and tuberous sclerosis. The second one is in high risk for development of brain abnormalities cases, such as fetal infections with positive amniotic fluid PCR, particularly CMV, ischemic events in a stressful maternal environment, etc. The third one is in abnormal skull biometry, so expressed as increased or decreased circumference or other abnormal biometric sonographic measurements of the brain structures. And the last one is one or several brain abnormalities identified on ultrasound, even in the case of a technically suboptimal scan to clarify whether they are isolated. So for fetal brain MRI, what are the common indications? So these might be findings that are noted or suspected on ultrasounds. There are generally three groups. First group are congenital abnormalities of brain or skull, such as the most common one is actually ventriculomegaly, suspicion of agenesis of corpus callosum, or midline abnormalities such as of the cavum septum pellucidum. The second group are vascular abnormalities of the brain. So they include vascular anomalies, hemorrhage, and monochorionic twin pregnancy complications. And the last group would be congenital anomalies of the spine, such as neurotube defects. The most common indication is ventriculomegaly. They make up about 40% of the referrals. Others are abnormalities of the corpus callosum, abnormalities of the posterior fossa, and again, complicated monochorionic twin pregnancies. Now, the next topic we'll cover is when do we do the fetal MRI? According to the ACR-SBR practice parameter for the safe and optimal performance of fetal MRI, pregnant patients can be accepted to undergo MRI scans at any stage of pregnancy if it is determined that the risk-benefit ratio to the patient warrants the study to be performed. There's no special consideration for any trimester in pregnancy. The theoretical RF power considerations that are greater at long exposure times and at a higher specific absorption rate. So we should be cautious as to how long the patient can be in the scanner. Normally, for my scans, I try to keep them below 1 hour. And postnatal studies have not demonstrated any impact on hearing or growth following prenatal MRI at 3 Tesla. So the next question is 1.5 Tesla better than 3 Tesla, or is 3 Tesla better than 1.5? How do they compare? At 1.5 Tesla, there is less artifact, and we know that it is safe. For 3 Tesla, it has the benefit of as a gain in signal to noise ratio. There's increased temporal resolution, better spatial resolution, greater shading, standing wave dielectric artifacts, so greater susceptibility artifacts, and there's greater banding artifacts. So the recommendations of Fetal Imaging Task Force of ESPR regarding preferred magnetic fields to be used for different indications in fetal MRI, what it says is if it is available, it is preferable to use 3T for neurological indications, especially involving the posterior fossa, lesions of the brain parenchyma, and small median structures. When available, 3T is preferred for indications of fetal body, especially to recognize herniated organs in cases of diaphragmatic hernia, to evaluate small abdominal and pelvic organs, and to evaluate cartilages. 1.5 is preferable in cases of polyhydramnios due to the more pronounced shielding effects and resultant artifacts at 3 Tesla. And GA should not affect the choice of magnetic field used. So this is gestational age. So there's no preference as to what age should go in the strength of the MR magnet. Now here are the images comparing the fetal brain at 26 weeks of gestational age, obtained at 1.5 Tesla, so that's the upper row, and 3 Tesla in the lower row. Though both 1.5 and 3 Tesla scans were performed on the same day, and the images from 3 Tesla show superior tissue contrast and conspicuity to that of 1.5 Tesla, as you can appreciate. Now, so we have established that MR is safe, that 3 Tesla is superior for neurological conditions in general. Then when should we perform the MRI? The need for early diagnosis should be balanced against the advantage of improved resolution and increased anatomic details later in pregnancy. Now, a 23-week fetus is actually very small. You compare here in this image the size of the fetal head of a 23-week fetus to that of the size of the mom's femoral head, right? It's just a bit bigger. So in practice, in reality, prior to 20 weeks, fetal MRI may give limited diagnostic information. According to the International Society of Ultrasound in Obstetrics and Gynecology, fetal MRI performed before 18 weeks does not usually provide information additional to that obtained on ultrasound. Most organs can be visualized in details between 26 and 32 weeks of pregnancy when pathologies related to abnormal development are more fully evolved. In addition, there's a key to interpretation of the examination. What that is lies in a multi-specialty collaborative approach. So these include experts in the fields of prenatal diagnosis, so our maternal fetal medicine colleagues, perinatology, neonatology, us, pediatric radiologists, neurology, genetics, and other related specialties. This multi-specialty approach allows for integration of clinical and family histories with the ultrasound and MRI findings to optimize patient care. And the patient should be counseled by a specialist who is experienced with that particular pathology for her fetus in order to provide her with the best counseling and management options. Right, so let's cover how we do fetal MRI. Let's ask ourselves, now, regarding preparation, which of the below is correct? Both 1.5 Tesla and 3 Tesla can be used for fetal imaging. Yes, we have discussed that. Maternal sedation is indicated. No, we don't need to give sedation to mom. Next one is, can we use cardiac coil? Yes, we can use any coil that gives us nice sequences, and we go into that later on. And we can put the patient in oblique, 45 degrees to the patient's left. You can put her supine, whichever way she's comfortable, lying still pretty much for 40 minutes to an hour. So this is our protocol. This protocol actually was published when we were using our old scanner, which was 1.5 Tesla. So the predominant sequences are actually T2 sequences. T1 sequence, I would like to go on to explain that actually T1, in addition to conventional TFE T1, we have been using snapshot inversion recovery, which is this sequence. Snapshot inversion recovery are more robust to patient motion and shows better anatomic delineation. So we call that SNAP IR. And the inversion time for SNAP IR is set to 400 millisecond, which enables gray-white matter contrast without placing neither tissue too close to its null point. The longer inversion time were more valuable to motion, more vulnerable to motion between inversion and readout, increasing vulnerability to artifacts. We set the field of view of 320 by 340 millimeters, which is sufficient to cover the required fetal anatomy over a wide range of gestations. In our center, we use echo time of around 8.6 milliseconds with a repetition time of 20,000 milliseconds. Now, when it comes to analyzing the fetal brain, we normally start with sulcal development because it is an important marker of fetal maturation. As sulcation increases with gestational age, for example, interhemorrhagic fissure is developed by 10 weeks, Sylvian fissure is 17 weeks, and the central sulcus is 27 weeks. So the pattern at 25 weeks is very much definitive pattern, like a newborn. Here is a normal 23 weeks fetus. We can appreciate on axial imaging the Sylvian fissures, interhemorrhagic fissure, on coronal image, hippocampal fissure, and on sagittal image, internal parietal occipital sulcus. Now let's take a look at this 35 weeks fetus. There are more sulcal development. So here is the Sylvian fissure, interhemorrhagic fissure, cavum septum pellucidum, hippocampal fissure, internal parietal occipital sulcus, central sulcus, superior temporal and inferior temporal sulci, parietal occipital sulcus, and calcarine sulcus. Neuronal migration occurs between the third and fourth month of gestation and is completed by approximately 24 weeks. On MR, neuronal migration is determined by the multi-layered appearance on T2 images. So on your left is a 21-week fetus. On this coronal image, we are able to observe 5 layers. So here's the inner germinal matrix. And then there's the periventricular fiber-rich zone, the hyperintense intermediate layer of migrating zone. Here's the subplate, which is a neuro-rich large extracellular matrix. And finally, the outer immature cortical plate. Just to contrast, here is on your right is the 35 weeks fetus. There's maturation into 2 layers now, so you only have the inner white matter and the outer cortex, similar to a neonate. In fetuses, the atria and occipital horns of the lateral ventricle appear prominent with respect to the frontal horns and should not be considered as an abnormal finding. Ventriculomegaly is defined as an atrial width equal or greater than 10 millimeters and can be measured on axial or coronal planes. The cavum septum pellucidum should always be observed after 20 weeks. And here are the normal corpus callosum. From your left is 23 weeks. We move to the right. We have 29 weeks, 35 weeks, and 37 gestational weeks. The rostral end of the corpus callosum first appeared by 12 weeks in the region that will later become the anterior body. Development progresses both caudally to form the body and splenium, and rostrally to form the genu and rostrum. The entire corpus callosum should be formed by 20th week, but it will continue to grow in size. The diagnosis of agenesis of corpus callosum is often difficult before 20 weeks due to the incomplete formation. And in the normal posterior fossa, we would want to look at the cerebellum and assess it in midline sagittal and coronal views to look at the vermis. We'll also look at the hemispheres in oblique and coronal views. It is important to measure. So in addition to morphological examination of the fetal brain, we assess the biometry. So here we can assess the 2D brain volume estimation using similar to what we do on obstetrics ultrasound. So we can measure the brain biparietal diameter, brain frontal occipital length in picture B, and in C is the skull occipital frontal diameter and skull biparietal diameter. We can also measure the head circumference, transverse cerebellar diameter, atrial diameter, which we mentioned previously. We also measure the vermian height, width, and the vermian area. There's an extremely useful centile calculator that is available online. And actually, this comes from Professor Mary Rutherford's when she published her data of total of 127 MRI examinations using a 1.5 Tesla scanner on fetuses with normal brain appearances from 21 to 38 gestational weeks. So she measured 2D and 3D biometric parameters, and this spreadsheet that is in front of you is freely downloadable, and it makes life much more easier when we measure and chart biometry against normative data. The most frequent indication for fetal MR is certainly ventriculomegaly. In ventriculomegaly, there is a myriad of associated abnormalities. The majority, up to 98% of children with isolated mild ventriculomegaly detected by ultrasound, are healthy at birth. So here it is. This is a 35 gestational weeks fetus. On axial image on the top, we can appreciate that there are parallel lateral ventricles. And there are lack of communicating fibers between the two hemispheres. On sagittal images in the lower row, there is absence of the corpus callosum, and the arrow indicates radial gyri, indicating that there is absence of the cingulate gyrus. This is another case, much younger, at 19 weeks with post-callosal agenesis. On top are axial images, and the below are coronal images. And again, it shows parallel lateral ventricles, colpocephaly, lack of communicating fibers between the two hemispheres, ventriculomegaly. So these findings are compatible with CCA. In addition, within the ventricles, we can see that there is a fluid level suggesting that there was prior intraventricular hemorrhage. There are various associations with colossal agenesis. These include Chiari malformation, Dendy-Walker malformation, gray matter heterotopia, holoprosencephaly, schizencephaly, and encephaloceles. So here are the example that you can see here showing that there's absence of corpus callosum and herniation of the cerebellar vermis. In this case, this is holoprosencephaly. And here is a case of schizencephaly with the large CSF cleft. And here is a case of encephalocele, also with herniated cerebellar vermis. In this case is a case of on ultrasound showing that there was monoventricle and anteriorly absent cavum septum pellucidum, separate occipital horns, and the thalami just look like one lump. They're fused or partially cleaved. And on MRI, it confirms that this is a case of semi-lobar holoprosencephaly, confirming the monoventricle anteriorly, absent cavum septum pellucidum, separate occipital horns, and the deficient anterior corpus callosum. Now, this is 23 gestational weeks presenting with mild ventriculomegaly. We can appreciate there's a large CSF cleft between the extra-axial space and the lateral ventricle on axial and coronal images. This is a case of open lip schizencephaly, which occurs at an incidence of 1.5 in 100,000 live births. It is also associated with other cerebral abnormalities in about 50 to 90%, and they include septic optical dysplasia, gray matter heterotopia, absent septum pellucidum, and dysgenesis of the corpus callosum. This is another case. Antenatal ultrasound detected a cystic lesion at the left parietal region proximal to the sagittal suture. At 23 weeks, MRI showed a well-defined cystic lesion at the left parasagittal region near the vertex, forming a focal bulge at the scalp. So it's quite easily detectable on fetal MRI. The signal parallels that of CSF on all sequences, and the brain itself showed normal myelination, sulcation, and gyration. So we performed a MR on day 0, and we noted that at the vertex, there is a mass that is of CSF signal and presence of a small amount of neural tissue within the lesion at its posterior aspect, which has herniated via a small 0.4 size calvario defect near the midline. And we also noted that there was vertical position of the straight sinus in addition to tenting of the tentorium. So this is a case of cephalocele. The cephalocele was repaired on day 0 of life, and intraoperatively, there's a narrow fistular communication into the intracranial compartments. So histologically, it demonstrated there was disorganized neuroglial tissue. So there it is. On your left is the baby at birth, and pretty much went straight to the operating theater for repair. And on your right is a photo post repair, and the scalp looks nice and smooth, and it was beautifully repaired by our neurosurgeons. MR is also helpful in evaluating abnormalities of the posterior fossa, especially in the third trimester, due to the progressive ossification of the skull vault. It becomes difficult on ultrasound. So MR allows this direct visualization of the hemispheres, vermis, brainstem, and the posterior fossa, and we can look for Dandy Walker malformation, cerebellar hypoplasia, cerebellar dysplasia, etc. This is a 22 weeks with fetal microcephaly, abnormal cerebellar shape, and suspected cortical malformation. So on the MR at 23 weeks, we noted there was a mildly enlarged posterior fossa. The fourth ventricle was uncovered with enlarged retrocerebellar CSF space. There's mild elevation of the tentorium and torcular, resulting in increased tegmental vermian angle. There's evidence of cerebellar vermian hypoplasia, and the cerebellum is also elevated and rotated. The brainstem is anteriorly displaced with obliteration of the prepontine and premedullary cisterns. For this case, the chromosomal study of amniotic fluid revealed a FOXC1 deletion, which is associated with cerebellar and posterior fossa malformation, including cerebellar vermian hypoplasia. Now, this is a 23 weeks fetus. You can see, very obvious, with this Chiari-2, and also there's spinal dysraphism. So what we did is we did predominant T2, took T2 images, and the sagittal and axial image showed that there was downward herniation of the cerebellar tonsils and vermis through the foramen magnum, which appears very crowded. There's ventriculomegaly. The head looks lemon-shaped, and there's low-lying conus on the sagittal sequences of the spine, and there's a focal posterior defect suggesting spinal dysraphism. Yet we could not identify a discrete extruded sac or placode. The fetus was terminated at 24 weeks, and these are the images of the fetus. And there was about a 2 by 1 centimeter skin defect in the scapular region, which had showed direct connection to the spinal canal, but again, there was no extruded sac or protrusion of the spinal cord tissue. So all this in keeping with spina bifida and suggested that there was a ruptured meningocele. This is a case of cerebellar hemorrhage, which was initially detected on fetal ultrasound. And on fetal MRI, the images in 3 planes confirmed that there was presence of blood products in the posterior fossa. And this fetus was also terminated, and subsequently on autopsy, it showed that there was a hematoma in the posterior fossa in this image at the bottom right corner. This is a 34 weeks gestation fetus. On axial images, there's a large cystic area in the left side of the posterior fossa. There's no communication with the fourth ventricle, and there was no vermian hypoplasia. So it was the cerebellar vermis was intact on coronal view, And all these images is suggestive that there's an arachnoid cyst in the posterior fossa. And the baby was born at term. It was neurologically unremarkable. And at 7 months of age, MR showed the arachnoid cyst has enlarged, resulting in mass effect on the left cerebellar hemisphere. There was also aqueduct compression. So also with obstructive hydrocephalus, and you can see the tentorium is elevated. And this baby went to surgery and had fenestration of the arachnoid cyst. I just want to share with you this recent story. Just want to demonstrate the often management of these fetuses require multidisciplinary. So there is collaboration between different teams and many times actually between different hospitals. So there's this case that's referred to our friendly adult hospital, maternal fetal medicine team from the private sector. So the question was that they noted that there was deformed spine and Chiari-2 malformation on antenatal ultrasound. So this was referred to the adults hospital in close to our children's hospital, and the adult maternal fetal medicine team referred the case to us for imaging. And so what we saw confirmed that there was microcephaly, there's a Chiari malformation, as well as spinal dysraphism, as you can appreciate on the sagittal images. And what happened is that between week 32 and week 37, there was multidisciplinary collaboration between maternal fetal medicine, pediatric neurology, NICU neurosurgery, children's hospitals radiology, our NICU, our critical care transport team, and our neurosurgical team. And in the end, the baby was born by cesarean section at the adult hospital, and our critical care transport team transferred the neonate to our neonatal ICU unit. So here is the baby at birth. And on day one, baby went to surgery, and the defect was repaired by neurosurgery and another hospital's plastic surgical team who came to join us at the operating theater. And then the baby was managed in our NICU, and our team performed a post-procedural follow-up MRI, which still showed that there's a low-lying conus, but the spinal dysraphism was nicely repaired. And again, we demonstrated the Chiari-2 malformation. In addition, in the brain, we noted that there was a gray matter heterotopia as well, which was not detected on fetal imaging. Now, lastly, just want to mention twin pregnancy complication. In neutral, death of a co-twin is associated with an increased risk of neurologic impairment in the survival twin. This occurs in complication of monochorionic twin pregnancies, such as co-twin demise and twin-twin transfusion syndrome. In a study of survivors of spontaneous monochorionic co-twin demise, MRI detected sonographically occult abnormalities in 1/3 of the cases. And these include polymicrogyria, encephalomalacia, germolytic cyst, hemorrhage, ventricular megaly, and delayed sulcation. So here is a 23 weeks fetus, monochorionic twin with one fetal demise at 16 to 18 weeks. And you can see the demise fetus, very small and low signal on the right hand side. And then here's the normal living fetus. You note the normal sulcation with interhemic fissure and sylvian fissures at this 23 gestational age. There's a tiny focus of germinal matrix hemorrhage right here. Low in signal intensity. And so again, you see the demise twin on the right-hand side, which is really small, and the morphology of its brain is barely discernible. The mother went on and decided to terminate the pregnancy just before the legal limit of 24 gestational weeks, but unfortunately she declined a post-mortem exam. This is another twin pregnancy at 23 weeks. Demise twin and coronal image shows encephalomalacia of the left frontal and parietal lobes with abnormal infoldings of the developing cortex that are consistent with polymicrogyria. So my last part in the next few minutes, I just want to mention something beyond the fetal brain. Now, here is on the top images, right? On the top images uh, belongs to a 35-year-old mother. So this is her first spontaneous pregnancy, and her congenital infection screen was negative. So on the top is we did the fetal MRI at 22 weeks of gestation, and it shows very interesting findings. We know that the interhemic fissure was present compared with gestational age. Sylvan fissure were actually shallow and barely discernible, as pointed out by the yellow arrows. We also noted nodularity in bilateral frontal and parietal cortices. So this is indicated by the red arrows. There is no gross malcalcifications. Corpus callosum was present. There was borderline ventriculomegaly. So we suspected that there was malformation of cortical development. Now, in the bottom row, these are abortus MRI performed at 24 gestational weeks. So this pregnancy was terminated, and we imaged the abortus. So again, on these images, you can see very nicely the gray-white matter differentiation. And here again, we showed that there was sylvan fissures were shallow. We note that there's parietal occipital fissure and hippocampal fissure were present, which are compatible with gestational age. Those thickened gray matter with nodularity in bilateral frontal and parietal lobes, as indicated by the red arrows. Again, no gross calcifications, and the cerebella was unremarkable. So all of these overall findings are suggestive of polymicrogyria, and polymicrogyria syndrome, such as bilateral frontal parietal polymicrogyria or OCLN mutations, were suggested to be considered. And the fetus, we also sent the abortus was sent to our pathology colleagues, who did a very nice autopsy, and they specifically looked at the brain, and the upper panels here you can see it's done with low field magnification, and the lower panels are higher magnification, and our pathologists very kindly shared control pictures with us as well, which are placed on the right-hand side of the slide. There is abnormal cortical folding noted in the case, and unfortunately, the whole exome sequences was negative, but it was nice to have these images and correlating with the findings that there was polymicrogyria on pathology as well. So why do we do postmortem imaging? Because accurate diagnosis of fetal demise is important in parental counseling and also planning of future pregnancies. The literature tells us that MR provides over 90% concordance for overall diagnosis compared to standard autopsy, especially for abnormalities of the heart, the brain, and musculoskeletal systems. 3T gives the benefit of higher field strength, and a lot of the times MR gives clinically useful information where neuropathology is non-diagnostic because of tissue autolysis. So this is another fetus that's referred to an adult hospital for small cerebellum and enlarged retrocerebellar CSF space and ventriculomegaly on 20 gestational weeks ultrasound. So this is the ultrasound image showing a very large retrocerebellar CSF space. So again, I just want to show you how we did these scans. Is after the termination, the abortus was sent down to MRI. This MRI was performed at the same hospital where baby was terminated, and the abortus MRI showed quite nicely of the enlarged retrocerebellar space. There was actually cerebellar vermian hypoplasia and a dilated third ventricle, and all of that in keeping with Dandy-Walker malformation. The body MRI was normal, but here I just want to show you how nicely MRI T2 weighted images would show on an abortus not only in the brain but also whole body. So this, in this case, it involved a FOXC1 gene deletion. Right. So here is another case, postmortem MRI of a 20 weeks fetus. We didn't manage to do a fetal MRI, but we did do a abortus MRI at 22 weeks. So similar to how we interpret the neonatal brain, here you can see that there's a large 3 centimeter T2 hyperintense signal lesion between the parietal and occipital horns in the midline. And this suggests an interhemisphere cyst, and it communicates with the third ventricle. And there are also several tiny T1 hyperintense, T2 hyperintense nodular lesions along the walls of bilateral lateral ventricles, and these could be due to prior hemorrhage. And we can compare this with the autopsy, and our anatomical pathologist confirmed complete absence of the corpus callosum. At the midline, he found a collapsed cyst wall, confirming that the cyst communicated with the posterior part of the high-lying third ventricle. So here, the findings on MRI and on autopsy confirm that this is a case of complete absence of corpus callosum with interhemisphere cyst. So to end this talk, this is a quick summary. I hope in the last 40 minutes or so, I've convinced you that MRI is very useful in providing additional diagnostic information and a change prognostic information in a lot of the times. The helpful sequences are T2 sequences and step inversion recovery, which is a T1 weighted sequence. Prior to 20 weeks, there's limited diagnostic information because the fetus is small. To be able to make clear diagnosis, we need to understand normal fetal development. We should take a multidisciplinary team approach in order to give the most wholesome care to the fetus and the mother. And MRI also provides excellent concordance for overall diagnosis compared to standard autopsy. So this is my second last slide. I just want to advertise for our upcoming Oceanic Society of Pediatric Radiology 25th anniversary. So the next meeting will be held in beautiful Doha in Qatar, and there is a fantastic scientific and social program on day 4. There's a postgraduate course. So I'd highly recommend you to go check out this website, aospl2025.org, and get more information. Do join us in October. That's a beautiful, beautiful time, 23rd, 26th of October in Doha. So with that, I would like to thank you very much for your attention, and you can reach me anytime via email, on Twitter, and do check out our hospital website. Thank you very much.
Thank you very much, Dr. Elaine Khan. It's been an exciting hour with you. I want to encourage everyone who has questions to use the chat box. There are already some questions there in the chat box, and I will read them out to you if that's okay.
Yep, sure. Yeah. I'm also looking at them.
All right. Okay, so the first question here on the chat box, asked by Dr. Obande Ogenyi, is the administration of gadolinium now safe in fetal MRI? It used to be a controversial issue. What
Right. So
sequences required?
there's so the two sides to the answer. First of all, there's not enough data to try out or in terms of gadolinium use in fetal MRI. In its use, let's say in first trimester, if it's really it has to be used, it's for maternal indication rather than for fetal indication. There is no fetal indication requiring gadolinium. So we don't use gadolinium in fetal MRI. Would that answer your question? So yeah, so if it needs to be done, then it's for maternal reason rather than for fetal.
Okay, thank you. The, the same person asked again that we saw the fetal MR images you showed at 35 and 37 weeks. If an anomaly is non-compatible with live, at such gestational age, for instance? What can be done at such a late GA?
Okay. Okay, so that's a really brilliant question. So scenarios that are non-compatible with life would actually be sometimes not neurological conditions, but perhaps something in like uh, renal hyperplasia or renal aplasia, where where we've seen in actually the past 6 months. So even in these conditions, fetal MRI would help in terms of counseling for the parents, perinatal care. So when after baby was born, that would prepare the neonatologist as when they stand by in the birthing suite or maternity suite, they have to be standby. What else support needs to be done in terms of the birthing process, in terms of the early days in life? Let's say whether the child, if it's renal hyperplasia, for example, if a renal team needs to attend to the patient. So all these, even though the prognosis might be poor, that prepares the medical team for the subsequent management, postnatal management of the baby.
Okay, thank you very much. Another question from Smarter. What are the theories for neurologic abnormalities in surviving twin in a vanishing twin syndrome?
Pardon, so hey, the question is what? Sorry, I'm not able to. Oh, okay, neurological. Oh, in vanishing twin syndromes. Um, I think what we worried or common indications for monochorionic twin when there is twin demise. In these cases, then we want to uh, delineate whether the surviving twin has any other neurological abnormalities. We're talking about these cases would be polymicrogyria, encephalomalacia, germinal hemorrhage, ventriculomegaly, commonly delayed sulcation. Sometimes this could be a process, whether it could be a systemic cause, whether it is due to infection, hypo perfusion related to placental health. So the physiology behind that would be whether there could be co-twin demise in the case of monochorionic twins because of the same physiology behind the demise twin. So I think these are the may not be the theories, but these are the neurological MRI findings we want to look for in the brain.
Okay, thank you. And the next question is, in the hospital protocol, aside an abortus MRI, do you also do a babygram?
Okay, that's a great question. So in traditionally, if we're looking at skeletal dysplasia, then babygram would be the most common examination to be done. So that usually is in the background of query whether there's skeletal dysplasia that might be due to short limbs that was already noted on antenatal ultrasound. For that indication, actually, a lot of times we would add on to, if the baby comes to our hospital, CT, because that would give us help us to have a three-dimensional reconstruction of the entire skeletal system. But for indications of brain abnormalities, we may or may not do the babygram, subject to whether there is any suspicion of spinal abnormality. And even that, usually MRI, if we're going to go on to the MRI, would give us more information and a better morphological delineation of the brain and the spine as compared to babygram.
Mute your microphone if you're not speaking. Okay. So our next question is, do you have experience with forensic MRI? for fetuses to determine cause of death in legal cases?
Thank you. That's a great question. Actually, we've just started doing some postmortem imaging in young children, unexplained death in children, or sudden unexplained death in children. The scope right now is for that we do pediatric deaths that present to, or that have not survived during their time in the emergency department, or those that have died at home that present to our colleagues at the Department of Forensics Pathology, which is under another section of the healthcare system in Hong Kong. So what happens is they would go from either hospital or home to the mortuary first, and then the forensics pathology may refer to us for further imaging. They already have a CT scanner, actually, so they would scan the whole body first. But to look at the neurological system, the brain or the spine, if that's the region of interest, they will refer to us. They would transport the body to us, and we would do the imaging. So we are just still at the learning period. In fact, a colleague of mine, I've just gone to Japan for a conference in forensics radiology this week, exactly to gain more experience and learn more on forensics MRI. So these cases, as you've asked, could be coroner's cases. They might not be. And so this is really depends on the clinical scenario and the initial forensics pathologist findings together with our radiology findings. Yeah.
Thank you very much. The last question here, before I call on Professor Bole, is there any age at which fetal MRI may be dangerous to a fetus?
Mm, I the what we the literature has found, there's several areas, is first of all, um, with the magnet, be it 1.5 Tesla or 3 Tesla, is the heat that's generated within the magnet. And that is, with these 2 decades of experience and research, is within safety limit. The second is the sound, whether it's safe for the fetus. And it's literature has demonstrated the decibel level is also within safety limit. So essentially, there is no age when it's not safe for the fetus to go into an MRI. But the question goes back to how much information we can gain from the scan. So before 20 gestational weeks, information is often limited from the fetus. You might want information from the placenta or for other maternal reasons that the mother needs to go in the scanner. But gaining information before 20 weeks from MRI might be limited compared to the amount of information you already gain from ultrasounds. So after 20 weeks, the literature shows us that there is additional information gained on MRI. But in terms of safety, there has not been safety issues from the literature for the past 2 decades with 1.5 or 3 Tesla scanners.
Thank you very much. Professor Obole, your hands is raised.
Yeah, thank you very much, Elaine. Dr. Elaine, I just want to thank you. My name is Godwin. I'm the president of the Neuroradiological Society of Nigeria. I just want to say a very big thank you to you for giving us this excellent lecture. I know it's very late at your end, and you've sacrificed so much to give us this very, very insightful and educative lecture. Just want to say thank you, and I want to say it's a marvelous lecture. Thank you so much.
Thank you so much, Dr. Bolly. When I first received your email, I was just completely amazed that you reached out to us in Asia, and I'm so honored to be with you across, the European continent all the way to Africa, and being able to make new friends. Reach out to people I normally would not be able to meet, but it's so nice to have this platform to be able to share our experiences, and similarly, we'd love to hear from you and hear you share with us your experiences as well.
Okay, that's fine. Thank you. We'll try and keep in touch. Definitely, like you said, we have your email, and hopefully some of us will be I don't know, in Doha, and like Doha is expensive. I'm sure you know, traveling from Africa is very expensive, but hopefully some of us will make it to Doha to be part of the conference.
Please do come and join us. Normally, it's actually further from you, right? We're normally the meetings are held in different parts of Asia, but this time is in Doha. So I do hope if you can, please come join us in Qatar.
Thank you so much. All right. All right. Fatade, I think we can end the meeting. Thank you. And like I said, people can still reach out to her by email and for collaborations. One of the things I want to say, I mean, fetal MRI is not something we do regularly or commonly in Africa. And I'm sure even within your circle, it's something very highly super specialized. Because especially you need a lot of experience, more so we don't have atlases to help you in making some of the diagnosis. You have to learn on the job. So I think it's a very specialized area, and I'm very happy that we have access to people like you, that if we begin to do this kind of investigations, we can actually, reach out to ask for some kind of expertise and opinions. Thank you so much.
Great. Yes, that's what we do. A lot of us pediatric radiologists, many of us who are interested in various aspects of pediatric neuroradiology, we always ask questions, that we have a very close community across the world, in the UK, in the US, in Canada, in Asia, and we all learn from each other. I think this is how we grow as a community, right?
Exactly. Thank you so much.
Thank you so much. I hope to see you again. We'll stay in touch.
We'll stay in touch. Thank you. Yeah. Have a
Okay. Have a
wonderful
good afternoon.
Good afternoon and good evening. Yeah.
Thank you very much.
Thank
Thank
you.
you.
Yeah.
Okay, bye-bye.
Bye.
Right. Thank you all our attendants, participants. Hope to see you at our next edition. God bless you. Enjoy the rest of your evening. Bye.
Thank you too.